So good afternoon, everyone. Thank you for joining us so much for this community education webinar, Road to Recovery, Responding to First Episode Psychosis. This webinar is being presented by Dr. Mackenzie Varkula, who is a psychiatrist and a member of the NAMI Greater Cleveland Board. We are very happy to have her presenting and sharing her expertise with us. Please note that this webinar is being recorded and will be available for viewing later this week on the NAMI Greater Cleveland YouTube channel. Just a few housekeeping notes. Please do remain muted throughout the presentation. Please utilize the chat feature. If you have questions, I will be monitoring the chat throughout the presentation so that I can keep an eye on any queries that come through for Dr. Varkula while she is presenting. We will also have time for questions when we come to the end of our program. I just want to say a few more words about NAMI Greater Cleveland for those of you who may not be altogether aware of the programs and services that we offer before we get started. So NAMI is the National Alliance on Mental Illness. It's a grassroots organization that was founded in 1979 in Wisconsin by a group of mothers of children with mental illness, specifically schizophrenia. And these women formed NAMI as a grassroots coalition around their kitchen tables because they wanted to create a movement to support more education and support and acknowledgement for families and communities affected by mental illness on local, state, and national levels. NAMI is now represented by state or local affiliates in all 50 states, and it is the largest grassroots mental health organization of its kind. NAMI Greater Cleveland is the local affiliate that serves Cuyahoga County, and our mission is dedicated to empowering those living with mental illness and their family and improving quality of life by providing education, support, information, and referral and advocacy. NAMI provides support groups for people with mental illness, support groups for families affected by mental illness. We have 8-week educational courses for families and for peers to learn more about mental health and their experiences. We do extensive community outreach and education to the broader public, including universities, law enforcement, middle schools and high schools, and hospitals and healthcare professionals, as well as corporate groups. And we have a helpline that is available Monday through Friday, 9 to 5, that can provide information and referral to appropriate mental health resources or other community services that may be beneficial for individuals affected by mental illness. And we also support advocacy in the sense of raising awareness about mental illness, making mental health a public health priority, engaging in legislative advocacy to promote greater funding for mental health services, and ensuring that peer and family voices are integrated into decision-making. So that's NAMI in a nutshell. With that being said, I will hand it over to Dr. Varkula to introduce herself and to carry us through this presentation. Thank you so much for being here.
Thank you, Matt. I appreciate being here. And I was telling Matt before I could talk all day, but I only have about 45 minutes. So what I would like to do for you is help you understand a little bit about new onset psychosis and the recovery from the process, the journey, how to manage, how to get the help you need. I am a psychiatrist. I am certified in child and adolescent as well as adult, which means that after medical school, I did a residency first in adult psychiatry, which is 3 or 4 years, and child psychiatry, which is 1 or 2 years. And the reason for that is you can overlap. So I did 5 years of training after. And a little bit of what I want to do today is help people understand all those letters, who's who and who do you want on your team. So the DO after my name is the proof that I went to medical school, and the board certification is that I've done residencies and taken a few extra tests. So those are always questions I get. Righty. So let's get moving forward. So my roadmap, this is a roadmap for recovery as well as for our talk today. We're going to start here on the bottom left and start with recognizing signs and symptoms of psychosis. How do you know when something's cooking, when something's boiling over? And then the acute care and stabilization phases, as well as putting together a team. Everybody needs a team. This is not a road you want to walk alone, nor do you have to. I always tell folks you don't get any prizes at the end for going this alone. In fact, you usually just need a few extra boxes of tissues if you're going it alone. And then a little bit of advice on my end of how to stay the course and maintain your recovery. So I want to let you know some of my sources because I'm not a big artist myself. I'm taking a number of visual aids from a few references. One is NAMI, obviously. I'm involved with the NAMI Greater Cleveland Board as well as the Ohio Board. I'm on the medical advisory board here in Greater Cleveland, which is it's very nice. Not every county or not every local organization has one. I've also taken some information from a couple of their sources I want to share with you. This SMI Advisor is a clinical sort of advice app and website, not only for families, patients, but also psychiatrists or mental or family practice doctors, neurologists, anybody. I can log on as a doctor or as a peer, as a family member, as well as SAMHSA, which is one of the government agencies that funds research and clinical care. So my first main point here is that any of this illness that we're going to talk about here is not a fault. The message is, for the most part, our understanding that there is some sort of genetic predisposition, and then your environment, stress, traumatic events, things that we can't control. This is not something that happens because of something an individual did or something a family member did. But it's definitely a complex interplay of biology and of environment and life experiences. A little bit of statistics, because I got to throw some in here. It's a lot of people, 1 in 25, a severe mental illness. And we're not saying severe mental illness to exclude. I want to define that for a second. Severe mental illness tends to relate to bipolar disorder, schizophrenia, chronic illnesses. If we were going to include potentially debilitating illnesses like anxiety, this would be 1 in 4. Anxiety tends to be more limited from a time frame and more straightforward from a treatment standpoint. So we're not going to be talking about generalized anxiety, things like that today. But if we are still looking at this 1 in 25 with severe mental illness, this is a lot of people. As Matt was alluding to from a public health standpoint, this is something that folks need to pay attention to. This is a large proportion of our population, and 1 in 25 means that it's someone that you know. So the first stop on our roadmap here, recognizing signs and symptoms. Psychosis can present very differently. It can be sneaky. Its onset can be slow. And people often looking back will say, my goodness, this may have been months or years in the making. And then that's true. Whereas another individual, it can be a very sudden onset. And I've had folks telling me things like it just seemed like all of a sudden, and people were looking for an accident or an injury to be the trigger. And sometimes there is a very clear trigger. Sometimes there is not a very clear trigger. Usually this is young adults or teenagers. We'll get into why in a minute. But some of the things that we look for in psychosis are probably the most commonly known to individuals are hallucinations. So the hearing, the seeing, the experiencing of sensations that other people don't hear or see. That's probably the medical students like to ask those questions of patients. Are you hearing anything, or are you seeing anything that other people don't? This can be frustrating for people. You know, do you hear that, Mom? Do you hear that? No, tell me about that. I think a trickier one is when we have individuals who are believing things, believing that they are in danger, for example, that other people just aren't seeing. And this can be a little bit frustrating for family members too, because it's hard to rationalize. I believe something based in fact, you believe something based in fact, but our facts are coming from different stimuli. What I see as a more sneaky onset or a slower onset of illness is this withdrawing from family, friends, not being oneself, not enjoying things, not doing things. And then there's the confusion piece where people have trouble thinking, have trouble concentrating. I have seen psychosis present as do I have ADHD, doc? And so this can certainly combine symptoms. You can see all of the above, you can see one of the above, but usually this is in folks who are teens, young adults. I have seen it. I probably the oldest patient I've seen with new onset psychotic illness is late 30s. So never say never in medicine though, but this is the age range in which we see the vast majority. So I said I was going to talk a little bit about why. And the two most frequent questions I get asked are why me and why now? So I put a couple pictures on here that I want to reference. And if my little cursor will follow us here. One thing can be physical illness. It can be related to genetics, which sometimes are at interplay with physical illness. It can be related to a psychological or a physical trauma, such as an accident or a brain injury, or a surgery even. I've seen folks get worse after very routine surgeries, sometimes substance use. And it's hard to predict. I can't tell people who are at risk. Perhaps I have a parent or two that have a psychotic illness. First degree relatives do play to increase an individual's chance of having an illness, but do not by any means indicate you are going to have an illness like schizophrenia, for example. If I were to have one parent with schizophrenia, my risk of developing a psychotic illness perhaps is closer than the 1% in the general population, takes it up to maybe 10 to 15%. And if I were to have two parents with a psychotic illness, then I'm up maybe 20 to 25% more, baseline risk. So that's still better than flip of a coin. I'm not likely to have this, but there is a significant genetic component. And why now? Why during adolescence? Well, if we look at this top picture, we see this super colorful brain, and we see all of these lines in here, and all these are neurons reaching out into the different parts of the brain. And these top parts are the cortex. This is what makes us human. These parts are what differentiate us from animals, reptiles, snails, all of those things. And these are the last parts to mature. So when we start with brain maturity, it starts with breathing and a sleep schedule and awake and alert. And those are the parts that we share with our reptile friends. They all have how to breathe, how to sleep. But it's these upper outer layers of the cortex that really help us be human. And those are the last to develop. And what do you know? They start developing and growing when we hit puberty. And so let's say puberty down here, look at all these neurons. These are cool pictures. So these are all neurons, and they're tentacles, if you will. And they're a little bit of a mess in puberty, which if anyone has survived puberty, you probably know that's why you feel a little funky during that time. But when we're done maturing around age 25, 26, we're going to have, hopefully, some really nice circuitry established. And this is a vulnerable time. Adolescence is a vulnerable time. We're maturing. We're going from a little bit of I keep jumping ahead here. A little bit of overgrown, and maybe like your garden when you've been gone for 2 weeks and you come back. We got to prune it back a little bit. We've got to establish some of these real nice, clear cortical pathways that help us connect emotions to behaviors. And myelination is the fancy word for maturity here. And that's going to go until your brain's still developing until 25 or 26. So that's why now. That's usually what I tell people, because your brain is trying to get organized. And what we see are this interplay of genetic factors. And I like to think of a jar, right? So I don't have an illness, but maybe these little red balls are some genetic predisposition. Maybe it runs in the family. Maybe I have some susceptibility that we don't know about yet in science, but makes me more likely than the average person to develop an illness. Then into that jar, we're going to add some of these blue, looks like little paintball explosions there. And those are our environmental or their vulnerability factors. So perhaps we sustain some abuse. we go through a very difficult time, we're in an accident. And once we get to a full jar there, it looks like psychosis. So that's another way to think of why now. Adolescence is this, development. Why at age 16? Why at age 22? Well, it may be that things have added to the point where your jar is full and now's your time. So that's just another way to think about it. Drugs, substance use can have an effect. Certainly there are drugs out there that people use on purpose to have some psychotic sort of experience. These are little research reports from NIDA, which is part of the NIH. People will take drugs to hallucinate, to experience the world differently. And usually the people don't argue with me about that. Did using LSD make me hallucinate? Usually people are open to, yeah, that might have influenced my experience a little bit, because that's often why they took the drug to begin with. What people don't bargain for, though, are the longer term effects of these hallucinations. People will approach a hallucinogenic substance and think, hey, I want to have this experience, I want to have a trip, and they don't think about it lasting for years or months. But sometimes we do see these hallucinations. I've seen people who see halos or see kind of shadows, like in this, I choose this picture on purpose, but will have their vision altered for months or for years. But it also can leave people paranoid or more moody than before their trip. And these things can last. And sometimes I would visualize them as those little blue dots, as maybe if I'm using some of these hallucinogens, that's an addition to my own personal jar, and may make me more likely to have these longer term effects, or move into a chronic illness. Other drugs, people often have a little bit of opinion and sometimes want to argue with me. No, I don't think marijuana could have just tipped me into psychosis. I see it, so I tend not to argue with people. I believe it can happen. This is different marijuana than in the 80s when we had the "this is your brain on drugs" type of situations. Marijuana today is estimated to be anywhere between 30 and 50 times more potent, for example, than it was in the 70s or early 80s. I have this in bright yellow here. This is a proposed label, in fact, for I believe it's California, but right now they're considering putting a label, kind of like on the label on cigarettes, that says this could lead to lung cancer. They're saying cannabis may increase your risk. The research here's just one review article in case folks are interested. The research suggests that if at baseline, your risk of developing a chronic severe mental illness is 1% of the population, daily use of medication, for example, marijuana, daily use can increase your risk to about 10%. And I chose this picture of this AKT gene variation, not because I'm going to get into any goofy genetics, that's a little bit over my head too, but because I like the picture. And if we have three people, one who's the AKT1, the second one here in the middle. So these are, let's have this visualize 3 different people. Never used cannabis, using cannabis at least, once a week, for example, and then using cannabis every day. This demonstrates that daily use can really increase the risk, especially in that teenage population. Like we talked about before, the why, it's because the brain is still developing. So a lot of times people will ask me as their psychiatrist, hey, my chronic pain, what do you think about using medical marijuana for chronic pain? Hey, if your brain is developed, I'm willing to discuss it. But if you're still a teenager or you're still in your early 20s, I usually recommend against it, because I want your brain to fully develop before we use. And that's pretty much where the research, I can answer you and say, hey, I have evidence to suggest that let's wait until your brain's done forming and then we can talk. And that's pretty consistent with what we know about alcohol. We know a little bit less about some of the other drugs commonly used, but I think because cannabis is the most common used, especially we look at teens, about 80% of teens are going to try marijuana before they graduate from high school. This is certainly something that from a public health standpoint, we want to educate people on. So like I said, is there a link? Yes. Research suggests 5 to 10% more likely. And so I tend to steer away from is marijuana bad or good. I tend to say, okay, what about for you? For you, if you're a 16-year-old and you're smoking weed every day, here's what you need to know. You are much more likely to develop a psychotic illness than if you are 26 and smoking marijuana every day for a prescribed reason or just because you want to. And I think one of the scarier things that I have seen, the first half of my career after training, I worked on an inpatient unit with teens and kids. And the second part now, I'm working in an outpatient setting. I think the scariest part that I see is folks can use marijuana pretty regularly, and then out of nowhere, they can see it kind of fill that jar, and now all of a sudden they're having symptoms. And it often doesn't make sense. You know, why now? Well, maybe one day we'll have a little bit better idea about why now. But I have seen people who have used for 20, 30 years. They come into the hospital thinking that maybe it was contaminated and their toxicology screen will show something else, but it was really just the marijuana. So hopefully one day we'll have a better idea to give people individual risks. But what I usually do is tell people when they come in having had a psychotic experience on marijuana, you probably want to look at it almost as like you have an allergy going forward. So that's usually how I advise people on that. So I want to get back a little bit to helping everybody here today understand, how do you know when it's a problem? Yeah, okay, people are hearing things, seeing things, acting funny. How do I know that this is a problem and what do I do? This is one of I was looking for a quote to kind of say what I was trying to come up with. And I always tell people, trust your gut. If you have a loved one or a friend or someone and you just have that gut feeling that something's wrong, it probably is. If you know someone well enough to know when something is off, trust that gut. Be a little bit more mindful, be a little bit more interested, because what probably is happening is you can sense it, but you haven't quite pieced it out. So this again is some of those symptoms that we reviewed before. A sudden decline in self-care is on the list here, but it can also be gradual. And what do we do, right? This is, I think, the tricky part, because this depends on what the individual you're concerned about is demonstrating. If someone is kind of paranoid and very concerned, feels that they're in danger, feels that someone's perhaps trying to hurt them, if you're trying to have them change their ideas or have them, reassure them, they may be a little bit paranoid of your intentions. They may be a little bit suspicious of, why are you telling me that? Why are you, when you've never cared about this before, telling me I don't need to be triple locking my doors at night? So approaching someone who's paranoid may take very different little needles than someone who is actively having a hallucination or a scary experience and is asking for help from you. So I have a couple resources here that give advice on how to start that conversation. And usually what I recommend, if I, to make a just a blank recommendation, is to be as minimally emotional as possible. You don't want to upset the person who is hopefully coming to you or you're approaching any further. So staying calm and offering a piece of something you notice. I notice you seem kind of upset lately. Tell me about what's bothering you. I notice that you're very concerned about your safety lately. Can you tell me, did something cause that? So I usually like to pick on a piece of shared reality. Okay, if I'm noticing, for example, someone's very concerned about a break-in or their own safety in their home, you can use something you notice about their behavior. I notice you've installed 3 new locks on your front door. Tell me what's going on with that. And this piece down at the bottom, be hopeful, supportive, and encouraging. I have found that even if it's your very first impulse, arguing tends not to be helpful and tends to, in fact, prevent people from sharing more. So it's not often helpful to challenge, especially if it's a hallucination or a paranoia. Instead, show empathy for how that person's feeling. Wow, you seem really, really concerned. What do you think we can do to help you stay calmer and solve this in a logical manner? Even if you know for sure this individual's not in danger, the point here is that they're concerned about their danger. And so that's why you want to be helpful. Now, if they are in danger, I've seen some folks end up in the hospital because they're concerned about a specific individual causing them harm. Then you want to be a little bit more aggressive in perhaps reaching out to services to be protective. But if this is a kind of vague, no specific other individuals involved, I think being empathetic is usually the best way to get someone to trust you and to share how they're feeling. The Best Center out of Neomed is another very nice resource for folks. If you Google this, I just copied and pasted because it was all so good. I couldn't just choose some of it. But these are some very nice tips and tricks. And, you know, when someone calls me and says, hey, you know what, my sister-in-law's worried about so-and-so, this is something that I'll often send them, or send them a link to something like this. And it's very nice, you know, don't joke. If someone is confused, they have trouble with humor, they have trouble with sarcasm. Okay. Don't make promises. I'm never going to put you in a hospital, because sometimes that might not be a promise you can keep. So these are some very nice tips that I think are very helpful to share when someone identifies you as, hey, you're someone who might know about this because of your association with NAMI. Can you help me out? Can you tell me what to do? I want to help. How do I help? And one of the biggest things that I think is a protective factor for people early in treatment or later is to have a team, to have this supportive social network here. And this includes, you know, family members are just as important as having a good doctor. Friends are just as important as having a good doctor. You don't want people to feel alone. You also don't want treatment to be a threat. And I think that can be scary too. We're looking for ways to build a character to motivate people to get help. Hey, you don't want to have to go to the hospital. Could easily be, listen, I don't want you to have to go to the hospital either, but I want you to feel better as fast as possible. So being very straightforward, not making threats, focusing on connection and empathy are usually the best ways to get someone aligned with you, so they feel like you're not there as a threat or to kind of take over, but that you can be a resource. People are often getting care, getting helped out of that hole from very different places. Now, ideally, you have a doctor already, you call your primary care doctor, or you have a counselor already, you call your counselor, and they can hook you up with the next step for getting care, for treating the psychosis. Some folks don't, and they are directed to care from crisis hotlines, from calling the NAMI helpline. Some people are going to present to the hospital because of acting strange. Sometimes people will be fearful that they had a stroke or that they have an infection. I have a number of people who will say, could it be a urinary tract infection? My grandfather was in a nursing home, had a UTI, and was acting very confused. And sometimes that's part of why we direct folks to the emergency room in the case of a change in, a change in their behavior, because we want to make sure that this isn't an infection, that there isn't something going on in the brain or in the body that is looking like a psychotic illness. And the last most common option is not my favorite, but sometimes it's court ordered. Sometimes behavior is getting folks the attention of the police, and sometimes they're all the way to being in front of a judge or magistrate when they are mandated to seek treatment. That's never my favorite, but we certainly are having more and more judges and police officers trained. We have mental health courts and we have CIT officers, and hopefully we are catching people earlier in the process before they're put in jail. They're taken to a hospital, for example, before they go all the way through trial and end up before a judge. They're routed to care providers. So hopefully, all of these stages have a role, some more than others. Here's my Ghostbusters reference. Who are you going to call? Who do you call in a crisis? Is it a crisis? I've had people ask me, do I go to the hospital? Do I not? And sometimes a phone call helps you decide, is this an emergency? Is this something that can be managed in a walk-in clinic, for example? And sometimes you want to reach out to a hotline simply to help decide, how do I get my loved one the best care at this point in time? So assuming that we are in some sort of crisis, that there is emotional upset, that there is the need to get help now, I usually recommend one of the crisis hotlines. And now, of course, we have the 988. Now, in our county, in Cuyahoga County, the 988 is replacing the Frontline Services 24-hour mobile crisis hotline, the 24-hour crisis hotline. Suicide Prevention Lifeline is now in it becoming one with the 988. So we have a combination of a lot of these services. They're not changing, they're just a more direct sort of access that you don't need to know the Suicide Prevention Lifeline when you just have 988. So these hotlines are out there. They are often connecting folks with the right type of help, because that's often the biggest, who do I call? What do I do? What do I need at this point in time for my loved one? What is this psychosis business? Psychosis is a couple things. It's a syndrome, like we talked about, right? That has these hallucinations. People can be paranoid. They can be disorganized. They can be losing personality. They can be losing interest. They can be just kind of staring at walls all day. But psychosis is also illness. And what we do on my end, when I see someone come into my outpatient office, emergency room, hospital, is say, okay, we got some psychosis cooking here right now. This could be a variety of things. It's very frustrating to people sometimes not to get a diagnosis right away. When I see someone as a doctor coming in with psychosis, I want to treat the psychosis. I want to get patient feeling better as fast as possible. And then we figure out, okay, what does this mean? What is this psychosis part of? Is this a medication induced? Is this an infection induced? Is this part of a bigger depression? Is this part of a more chronic mental illness? But the first goal of this acute treatment is going to be getting an individual in front of a provider and getting some relief. And then we're going to move on. That establishing a diagnosis can sometimes take days, weeks, months, and that's very frustrating. However, what I want to do today is assure you that a number of these medications that we use in the acute time, so first day, day 1, day 3, day 5, these are medications that are helpful for psychosis, whether it's part of a mood disorder, whether it's part of a psychotic disorder. And what we're going to do to help your loved one in the moment can be part of treatment of schizophrenia, can be part of major depression going forward. So first goal is going to be get an individual feeling better, then look at what we need to do to treat the underlying illness. I often compare it to pain. It's emotional pain. We want someone's pain to be controlled. Then we find out, how do we fix the break, the injury, the infection, right? So calm the individual, then move forward. And one of the biggest differentiations that we need to make, which does help from a medication standpoint, is there a mood component? Is this a depression? Is this a bipolar disorder? This is helpful to know from an expectation standpoint. These are folks that are going to get better faster and be more likely to live independently. In the long term, it's a chronic disease, major depression, bipolar disorder, but often people get 100% better. Psychotic illness doesn't always happen that way. I was taught when I was in medical school that if you can get someone back to 95% their prior functioning with each psychotic episode, that's great. You may, and that's important to know from how much medication am I going to give someone? How aggressive am I going to be in treatment? Can I get them back to 100%? It's usually going to be my goal, but may not always happen. These are more severe illnesses from a brain standpoint. And we often think of schizophrenia and schizoaffective disorder, excuse me, as degenerative diseases instead of just a chronic disease. Medications are only part of the pie. They are usually an initial part of the pie because they have to do with that calming of the pain. I want you to calm. I want you to feel better so that then we can move forward with the other stuff. And while yes, medications are important and definitely can affect how quickly you're going to get better, how big of a side effect load you're going to have down the road. It is important to remember that medications are not the end of your recovery. And sometimes that's hard to get buy-in. As Americans, I think we're primed to take our pill, feel better, and go about our business. So I often will, when we're talking about medicines, we'll say, okay, here's the medicine. We're going to get to the rest of the pie later. This isn't going to be the whole treatment. And like I said, this acute phase is about helping the individual calm, comfort, quiet. I can't expect someone to be part of the treatment team like I expect an individual to be if they're in pain. So we need to get folks feeling better, feeling safe, so that we can then work together. You're more likely to be able to tell me how you're feeling and what I can do to help you if you can think rationally and if you're not upset. And so that's going to be my first goal, so that I can get you to be a productive part of telling me how you need me to help you. It can be overwhelming. I think when folks end up in the hospital, I pulled a recent patient who was discharged from the hospital and came back to me. This is an example of what an individual who was later diagnosed with bipolar disorder was started on. And part of why I'm bringing this up is to show you that this is typical. I think people get overwhelmed. Why isn't this just one pill like when I had strep throat? All right, we've got a list here, and I'm going to explain to you a little bit as to why there may be a whole list of medicines when you go to visit someone. And there we go. So if you see this list, it can look overwhelming. And yes, if you're seeing a list twice this long, absolutely ask questions. One of the things I encourage people to do on the first meeting with a doctor, whether you're the individual or whether you are a family member, is ask for a printout. Because during your meeting, you can do something like this. What is this quetiapine business? Okay, that's a medication, maybe also known as Seroquel. It is a medication that is designed to treat the psychosis itself. Good. What is this lorazepam business? Well, when you're not feeling, you can be a little bit anxious. Okay, so this is something as needed, not every day, only as needed for anxiety. And we can go through. Often what the folks in the hospital will do are add these PRN medications. I think anyone who's been in a hospital before can respect that PRN is a very, we don't do a good job of letting people know what a PRN medication is. It's an as needed medication. And what it does is allows the patient and the nurse to have a communication about what you need. Do you need extra help without having to wait for the doctor? Because that can sometimes be a pain in the rear. So a lot of times there will be some of these as needed medications that individuals can ask for. And I don't limit these to the hospital. I will often, when people come out of the hospital and talk to me, they will say, hey, in the hospital, I had a rescue medicine. I had a medicine like this benztropine for if I was having some muscle twitching. I had some lorazepam that if I was really freaking out, I had something I could take. And so some people call them PRNs, some people call them rescue medications, but I think it's very important to understand that these are shorter term or as needed compared to your basic medication like the antipsychotic here. Here are some examples that I think everybody should ask their doctor. Are these antipsychotics typical or atypical? And this is a class. This is important to know because they have different types of side effects. Are these a scheduled or as needed type of medicine? I typed on here the orange pills, for example, and I chose quetiapine on purpose, not because they're paying me. They are not. Antipsychotic, and then it's also an antidepressant. So I always think it's important to know who's your employee. If this orange medicine is something I have to take every day, I may give my patient a little sticker to put on the bottle from the pharmacy. This is not only my antipsychotic, but it's my antidepressant too. I expect this guy to do double duty for me. And I think that that's really important too, to know what are your medicines supposed to be doing? Because very rarely are they going to work right away. Some of those as needed medications are, and they're rescue medicines. But why am I taking this yellow pill? I haven't noticed any difference. Well, maybe that's something that when you go back here, we need to write down. Valproic acid twice a day isn't going to do anything for 5 to 10 days. You need to take it for 2 to 3 weeks before you start seeing a benefit. Those are things that you want to know about as far as an expectation as medicine. Are these medicines I'm always going to have to take? How long do you think I need them? Are they something that I could maybe get a once a month injection instead of taking this medication every day? Some medications come in long-acting injectables, whereas others don't. And that's something, if I'm someone who's not good at taking medicines, I know that about myself, or my mom can say to my doctor, listen, she's terrible at taking her blood pressure medicine. This might be an issue. Maybe I, as the doctor, choose a medication for you that is going to be a monthly or every 3-month injection so that we don't have to worry about me staying on my medicines. This other question, which are must-take medicines? I think it's very important to let people know why they're taking a pill, what it's doing for them, and what can happen if and when you do stop it. Also, when should you definitely stop it? What are some funky sort of side effects you might want to look into? All right, here are some websites. I think the link will work, but this severe mental illness advisor that let's see, here's the website. It'll link us right here to, you can look up all different medications. That's people always say, what's a reliable starting off place? Also NAMI. And when I think about medications, I not only think about what they're taking, what they're supposed to do, but these practical things, right? Like, how am I going to remember to take medicine twice a day? Am I taking an injectable and oral? Are there ways that I can use technology like my phone to help remind me? It's not just the taking of the pill. Now, once this is my second stop, stabilization, right? Now that I've got the pain under control, now that you're in a place where you can start working with your providers, now we can talk about getting you feeling better for real. We've quieted the pain, but now we got to get to the rest of the pie. And that's where we're going to talk about what happens. The stabilization piece, there's a lot of talking. So if you're not a good talker, or you're still having trouble remembering, this is when you need a secretary. You need to get an administrative assistant who's in there to take notes. Your sister, your child, your mother, your spouse, someone who's going to be able to remember and help you organize, excuse me, and help. If this is an illness that's going to require you to take medicine on a daily basis, you might not like that. There might be some anger there. There might be some why me. There are countless ways of people adjusting to getting an illness, just as there are studies done on when people hear the word cancer. They don't hear anything after that. You got to schedule a follow-up appointment. So I think it's really important to be clear with any of these folks who are doing maybe a drug information session in the hospital, or you're meeting with a new therapist, to say, hey, I'm really upset about this diagnosis. I'm really not happy that I'm taking medicine. And you share those feelings and state of minds, because that's going to allow people to give you maybe only as much information as you need right now. And maybe your sessions with the therapist are just going to be venting. Maybe you're not problem solving right away. But the more you can share with individuals who are joining your team, the better you're going to be able to have your needs met. Other things that I see now in hospitals we didn't have 15 years ago when I worked inpatient, meeting with a nutritionist before you leave. Are there things I need to know about my medicine that are going to affect my diet? Hey, I've never tried yoga before. It's kind of cool. Or I used to meditate, but now I can't. So I got to find something else. Sleep habits are a big one. Severe mental illness tends to affect sleep cycles, but also be very sensitive to changes in sleep cycle. So there are other things here that we need to learn about and find out what's a good fit. Not everybody wants to do yoga, and that's okay. but finding a way, maybe taking a walk every day through nature or driving through a park is going to be something. Nature therapy is going to be a better match for you than yoga, for example. Stabilization and team building, I'm flowing together because this happens together. I have a link here for you, a great NAMI website that's kind of, I could also call it a who's who of your treatment team. But I think it's important sometimes to know, do I need a psychologist or is a therapist okay? You don't need someone with a PhD if you're looking for ways of coping with having mental illness. If you are getting psychological testing done, however, you may want someone with one of these PhD or PsyDs on board. So I like this website because it tells who can prescribe medicine, who is a type of therapist. Do I need a psychologist and a social worker? What's the role of my primary care physician? These are things that I think are important and often deserve some sort of chart. Or I always think of it as like reading a play in high school when I studied Romeo and Juliet in 9th grade. At the very beginning, cast of characters, right? Who's who, what's their job, and what's their phone number. I love it. Now, sometimes the whole team is in one place, and this is a CSC, or a coordinated specialty care. So that this chart here is very similar to this pink one. These are known as FIRST programs, and they are often very, very helpful to folks who've been diagnosed with a new onset psychosis, because this team is already in a position to work with each other. Often they're under the same roof, or at least using the same type of technology to talk with each other. I think since the pandemic, some of these folks might be not quite under the same roof anymore, but certainly coordinated care. And there is a link here. My slides should be available to you online so you can get all this, but FIRST programs throughout the state. So again, someone knows you're, excuse me, connected with NAMI. So they call you and they say, hey, I have someone down near Cincinnati, out in the middle of nowhere, Claremont County. How do I help them find care? All right, so we're going to scroll down here. There is a FIRST program down in Cincinnati, and here's the individual's contact information. Hopefully, if you're coming out of a hospital, for example, they will help refer you to one of these programs where they're going to say, hey, you're going to get a case manager, you're going to get medication therapy, you're going to get all those things that you need. If you're in a place where you prefer not to use a FIRST program, or there's not one available, or there's a wait, for example, you may be seeing individual providers, and that's okay, as long as they're willing to talk to each other. I tend not to refer my patients to therapists or caseworkers who won't call me back. So it's okay to have, especially in private insured individuals, that they may have a harder time finding a place that has everything under one roof. I want a case manager to help me with independent or supported, excuse me, housing or supported work. That person needs to know when I'm making med changes with my doctor. So it's okay to have people who are not all working for the same agency as long as they're willing to talk. Community mental health agencies also tend to have everything under one roof. Assertive community treatment, or ACT teams. We have one in Cuyahoga County. We also have a transitional age ACT team in Cuyahoga County for that 16 to 26 population. And then there's the support. You need oops, oh my goodness gracious. I know I'm running out of time here, but I'm not ready yet. Also need support, because this isn't easy. And like I said, you're not going to get an award for going through it alone. So think about NAMI. Think about what's important to you. Do I belong to a faith-based culture? Do I have a church, a synagogue? Do I have a clubhouse? Do I have family? And if I don't have close family or a church that I'm already involved with, who's going to help refer me? Probably everybody. I have patients, for example, who will be tired of me trying to get them to go to clubhouses. Magnolia Clubhouse is the one we have up here in Cuyahoga County. It's amazing. It gives people access to advice, to activities, to support, to supported work, and it's available. You just show up. NAMI peer-to-peer is a little bit more organized. I tell all my patients coming out of the hospital, you got to learn, knowledge is power. And these are people who know. I'm in charge of your medicine. You're in charge of your medicine, but you also need to be in charge of figuring out how to live with an illness. This is like in diabetes. You're not just diagnosed with diabetes and given insulin. You're sent to see a nutritionist and an exercise physiologist. You're part of a group to help you cope with having a mental illness. A lot of times people will transition out of the everyday hospital to more supportive programs. They're not just going to have a therapist once a week and a case manager once a week. That's like 2 hours a week, right? So a lot of times you can transition to home and get that kind of day program experience, or 3 hours, 4 times a day of an intensive outpatient program. This allows people to transition home, but still get daily support that's more than just a phone call at the end of the day from your doctor. I may not be able to help you with some of the more impactful things that have changed. I may need to change jobs. I may need to move. I may be staying at my mom's house, but these connections are going to be just as important. These are the other parts of the pie. And I didn't, just accidentally choose that pie picture. The medicine's a small piece. All of these other ways are how you're going to stabilize and how you're going to stay the course, how you're going to continue to get well until you're back to yourself, and how you're going to stay well. I often also tell my patients, you need to have a safety plan. Sometimes family members are the ones that insist on it because they're anxious too. They want to help, but they don't always know how to be helpful. So here's what I tell people. If you get sick again, what do you want to happen? And this SMI advisor has a very nice app that you can go through with your counselor, with your parent, with your spouse, with your doctor, and go through, hey, if I get sick again, here's the hospital I want to go to. If I get sick again, I don't want that medicine as an as needed in the hospital. I prefer this other medicine as an as needed in the hospital. And it's almost like a way of making sure that you're documenting, and you have this on your phone, so I can show it to any emergency room I roll into. I can say to my doctor in any hospital I roll into, hey, let me get my phone. Or my mom can say, so-and-so has this mental health crisis plan. Can we pull it out? Trust me, a doctor's going to be really happy that you've discussed this while you're feeling good and rational. Another one I love, this is an app called Not Okay. You prime it with people you trust, with information, and all an individual has to do is press Not Okay button. And it goes through this, and it's going to send out a text to, if I have 5 people on there, it's going to send out 5. I might not see the text, but I might see that my husband responded to my son's I'm not okay. So I don't have to panic and think, oh my goodness, did someone call him back? And so this is a really nice tool that you can try out. And this isn't just for mental health. I've seen folks with seizures using this. I have had people tell me when they feel low blood sugar, for example, I've shared this Not Okay app. But people have used it for other connectivity issues, needing to reach someone quick. I am going to include here just some references. I talked about the first program briefly. Catholic Charities is the agency in Cleveland that runs our first program. I showed you that website where you can look at any of the counties in Ohio and what their programs are. Certainly phone numbers, links, this best practices where I showed you the tips on how to engage someone. This talks just a little bit more about what some of the first programs offer and why you might want to call them, as opposed to just getting a doctor when you leave the hospital, or when you leave your doctor's office and you think, do I really need to get all these people involved? Here's why you need a team. This is what they can do for you. And here's some other really just, if you're going to jump online, I've learned people like to jump online. I want you to start at good places. I want you to have trustworthy places to jump off to start your online search. And then here's another specialized resource we don't have time to go into, but for individuals who are planning pregnancies, who are pregnant, this is a really nice, it's mothertobaby.org, but the link should work if you do have my slides to go directly to it. Because mamas get sick too, and we got to take care of them because there's babies involved as well. So I am going to pause, and I'm going to let Matt direct me to any questions. I know I covered a lot of information. I apologize. I told you I could talk all day, but I'm happy to take questions or elaborate at this point if anybody has anything for me.
Thank you so much, Dr. Varkula. And we do have a few minutes for questions. And there is one question in the chat. This is from Lisa, which is, can you discuss how or why a diagnosis might change from childhood bipolar to schizophrenia in late adolescence?
That is a great question, Lisa. And there's probably a few different answers. I see, especially working with kids and with adults, I see people who will come in and tell me, I have all the Ds. I've been diagnosed with all the disorders. I don't know which one I have. Maybe I have them all. And I think what we see is that sometimes when an individual comes into a hospital, or when an individual comes in front of the diagnosing provider, I'm going to use me as an example just for ease of discussion. If someone comes to me and they're having psychosis, like I said, I have this differential. Could it be depression? Could it be schizophrenia? Could it be bipolar disorder? Could it be an illness? And what I'm trying to do are eliminating things. Sometimes people will be assigned a diagnosis because that's just the most likely thing it is. If I have a child come in who's psychotic, hasn't slept in a week, and is describing to me how they're going to fix global warming. Okay. We've got psychosis, we've got probably some mania, not sleeping, grandiose, lots of talking, probably bipolar disorder. However, at that point in time, I see them together. I don't know which came first. So probably the easiest mistake for me as a provider at that point to say, do you have bipolar disorder or do you have schizoaffective disorder? What came first? Do you have mood without psychosis? Or do you sometimes have psychosis without mania? And so sometimes what'll happen, and blame insurance companies on this because we can, I need to give you a diagnosis to get things paid for, to get medication covered, to get your insurance to pay for things. So I have to choose one. Now, I could say that this is like an unspecified psychotic illness, but a lot of times that's not going to get you the medication covered that I want to start you on. So I may say to you, or I may say to your parent, listen, I don't know exactly what's going on here, but I need to pick a diagnosis for the purpose of paperwork. I'm going to call this bipolar disorder, but here's what I want you to know down the road. If we see the mood clear up and the psychosis continues, or 5 years from now, you have a psychotic episode without mood, that may then down the road help us understand, you know what, maybe the psychosis came first. Maybe it's schizoaffective as opposed to bipolar disorder. Even if all of these discussions happen, and not every doctor is going to sit down and have that discussion with you when your child's 14. Your 14-year-old grows up and is 24, was sick at the time, even if that 14-year-old was part of the discussion, may not remember it, may simply remember or have access to the paper that says bipolar disorder. So there is a lot of movement within what's my diagnosis, partially because of labeling necessity, because of insurance necessity, but also sometimes because of we're going to call it what it looks like, but we don't know the before always, and we don't know the after always. And those are just as important as what we see when I have an individual in front of me.
So another couple of questions if we have time. One question is, this comes from Justin, and he says, it is a struggle to get good information from inpatient treatment centers and treatment providers in general. How do you navigate this? There has been major gaps in coordinating my family member's care when she gets released from inpatient facilities.
Absolutely. And my answer to that would be the best friend of the social worker. A lot of times people want the doctor because the doctor is the final say, right? Let me tell you a secret about doctors. We are not always the most helpful people. What I recommend is ask for and advocate for a family meeting before discharge. Even if you have to refuse to go pick up your family member before discharge, I need a meeting. We need to understand. I would like to have the doctor there. But what you really, really want is that social worker to be on your team, advocate for you with the doctor, to either have the doctor be able to answer questions. A lot of times the doctor will come in for 5 minutes, sit down, answer medicine questions, and then skedaddle off. But what you want is to be kind of the squeaky wheel. And I also always encourage people to ask for things in writing. Ask for the med list. Go through the med list like I did for you and write down what you're taking and why. Save copies of those. Start a binder. I love nothing more than if someone comes in and says to me, I've been hospitalized 5 times, or, my son's been hospitalized 5 times. Here's the discharge instructions, because I'm not going to get a really good idea and start it and waste that hospitalization if you've tried it 3 hospitals ago. I want to be mindful of your time and getting you feeling better as fast as possible. So I would encourage you to advocate for yourself with the social worker or care manager in the hospital. That person is most likely to advocate for you with all the other members of the team, with the nurse, with the doctor, and then ask for copies of everything, because you're going to be able then to reference those documents. Hey, you just told me this, but here's what I see here. Help me understand why. So those are, be the social worker's best friend, get everything in writing.
And maybe one more question, since it's a great one, and I think you might have some good thoughts on it. So this comes from Daniel. Have you found that teens that use substance regularly, particularly cannabis, respond better to certain resources when shown the risks? Examples being parents, doctors, or peers.
Yes. So one great question, Daniel. You must be a parent, huh? One of the things that I like to think about are no teens, right? They're obnoxious. And they're going to argue with you. And if they're 15, no one knows less in the world than their parent. So I often will have parents send me a message ahead of time and say, listen, I know my son needs to do this. Can you please suggest it? Because if I suggest it, he's not going to do it. So I always encourage parents to kind of have backdoor communication with me via email, via phone, via fax, whatever you have it. Listen, he's not getting to bed on time. Listen, he's on the phone with his girlfriend every night. And those are things that then maybe I can say, hey, what are you unhappy with? Oh, you're tired all the time. Yeah, it could be your medicine, but are you turning off your phone? Because your brain is very susceptible to sleep deprivation. And one thing you can do for yourself, what I try and do is empower that teen. And if you know as a parent what is part of the problem, let me know. I'm happy to be the deliverer of the messenger. If you don't know, hey, my kid's tired all the time. What is going on? Well, maybe he's sneaking the phone. Maybe you've locked it up. And so good communication as a parent with the doctor, even if it's not by phone, even if it's a quick fax or an email to the office. Hey, please get this to Dr. V before my appointment with my son. If your child is 19, for example, he may not allow me to call you and talk to you, but he can't stop me from getting information from you. He can't stop me from receiving information from you. And let me tell you, the more information I can get, the better. I have like a photograph. When I have someone in front of me, it's just a little photo. A lot of people can keep things together when they're in front of the doctor and then fall apart when they go home. So whatever information you can give your doctor, the better. And especially if you are losing some of those teenage fights, because you do, and you got to parent these kids anyway, even if they're sick kids. You got to parent them. So some of those issues, they're going to be very helpful for the doctor to know, and for the doctor or prescriber to know ahead of time, so that I can kind of strategize my take and my, half an hour with that child. Great question.
Thank you. And I am a parent.
Oh, bless you, Daniel.
Thank you, Dr. Varkula, for answering those questions.
Oh, my pleasure.
Final notes here. I did put the link for the chat or for the survey in the chat once again. Please do fill that out. These slides will be emailed to all of you later today, and we will also have the recording of this webinar on the NAMI Greater Cleveland YouTube channel sometime later this week. So you can view it, you can view the slides, click on the links in the slides, and thank you so much for joining us, and have a great day, everyone.
Thank you.